Hello again. So, कहाँ से आगे करें? You? ठीक है. So, Nai Zindagi was started in 1989 by a group of people who were affected by drug use. Nai Zindagi believes in providing rights-based, evidence-based, scientific treatment options to people who use drugs, their partners and spouses. All our services are geared towards making their lives easier because it doesn't make sense to develop something at the top and implement it. So all our decisions come from the community as they should for any intervention. I think there's something wrong with this. Okay. Anyway, so in this you can see half. Reset कर दें. I think this page is cut. Anyway. जी ऐसे ही कर रही हूँ. I'm just trying to see if we can get the picture so you can see the services. But okay, so we believe in outreach. We have around 800 outreach staff of 800 who go out. Our first point of contact with the client is at the spot. So you can see half the picture. There's a outreach worker on a mobile, and we provide a HIV prevention package which includes 3 syringes of their choice. We do a survey to determine which syringe the client prefers. 3 needles, spirit swabs, bandages, and condoms are available on demand. Our outreach worker also motivates them for HDC testing. We have mobile vans that go to these spots and test the clients voluntarily, confidentially. Once the client agrees, if the client is positive and wants treatment, we link them to the ART centers, which are provincially run. Once they get the medicine from the ART centers, then we facilitate them to go to our ART adherence units. Our ART adherence units are residential, 3 to 6 week residential facilities. We came up with this with our Dutch partner mainline in 2015. The physicians at that point were reluctant to link our clients to ARVs. And because there was no OMT, we came up with this facility where clients can come, get a break from chaotic drug use, understand what, get withdrawal management, understand what HIV is, how to protect themselves, how to protect their families. So the residential facility has residential doctors, psychologists, and all the counselors we hire are people who've been through the program and are HIV positive and have experienced drug use. Then we also have, once the clients leave our ART adherence unit and they go back, we have social mobilizers who support them to go to the ART centers to get the medicines. We also have a spouse program. We're operating in 58 districts from 45 continuum of prevention and care sites. Each site has female outreach workers. Once the client gives us permission, we access their houses, test their spouses, test their children, link them to treatment and PPTCT. Then we also have central procurement to make sure that all our supplies are verified. They're procured high quality supplies and distributed to our continuum of prevention and care sites via a reliable service provider. Currently it's TCS. This is the ART adherence unit. This was an independent study done to show that people who've been through the ART adherence unit are more likely to be adherent to treatment, which also makes a logical sense. This is our coverage. We're in 58 districts. We're covering all of Punjab, most of Sindh, in KP and Balochistan. In KP, we'd started full-fledged sites, but there wasn't enough evidence to continue them, so we've have satellite sites there. And in Balochistan also the trend is still to smoke as it is in KP. Once, if you're closer to the border, you notice that because the stuff coming in is purer, people are more likely to smoke, chase, snort, and there isn't evidence of so much injecting over there. Punjab and Sindh, Punjab has the highest burden because it has the highest population. So yeah. We have 4 ART adherence units. One is in Sindh, in Thatta. Balochistan is covered in the Sindh, via the Sindh ART adherence unit, and KP is covered via the one in Rawalpindi. This is the data from 2012 to 23. Around 90,000 PWID have been tested, 22,000 registered to ARVs, 18,000 issued ARVs. However, unfortunately, the numbers are of people currently on treatment are very low for multiple reasons, which Salman Saab also explained in his presentation. One of the main ones being lack of differentiated service delivery in Punjab. So we reach around 45,000 people who inject drugs annually and distribute 20,000 clean sterile syringes every day at 500 spots across Pakistan. The only day we don't operate is Sunday, and on Saturday we give the service for Sunday. We also have paramedics on each of our sites who go to provide antiseptic dressing and basic, and then we have doctors contracted near the spots who provide basic medical care to those clients who need it. So we started our prison program in September 2021. We did a need assessment, and we were very grateful to the IG Prison Sindh who allowed us access to Malir prison. We did a need assessment, and now we have 2 HDC counselors hired by Zindagi, 1 social mobilizer / paramedic, and 1 data entry operator. So this enables us to link clients who are already in our services to medicine, to test clients, to link their spouses to treatment also, and to provide ARVs within the prisons. In Malir prison and in Central prison, we have our own staff in the prisons because the numbers are high, but in all other prisons of Sindh, we are covering it through our existing COPC sites because the numbers of people who use drugs in those prisons are low. We are also in the women prisons in Sindh. We've started in KP, and we're very grateful to the KP government, and we are starting soon in Balochistan in Quetta also. In 2015, we started district AIDS councils. The purpose of this was to make the districts, to allow them to take ownership and to ensure that our clients and our outreach workers were protected. So far we have 22 district aid councils, and the composition includes district administration, health police, prisons, social welfare education, local influencers, NGOs, and local medias. It helps develop ownership of the HIV response among local authorities. It's very rare now that our outreach workers are disturbed while giving services. We also have point of care viral load testing. The reason for this was that we weren't receiving results of viral load for our clients, and therefore could not determine the benefit of, to determine the adherence. So we started again with mainline. We did a small pilot. We hired technicians and got a portable gene expert machine which traveled to different districts to get the viral load tests. So far we have tested, and then Global Fund took over the project. Now we have 4 gene expert machines, and we've determined their rounds to ensure that whenever somebody is due, we can get their viral load tests. The benefit of this is, one, we can motivate our clients if the viral load is not suppressed to take the medicine. If they are taking the medicine, we can let the physicians know, because the results are also given to the ART centers as soon as we get them, and when the client goes for a visit, it's sent with the client, brought with the client. So far 8,140 individual PWID and 720 spouses have been tested, And the viral suppression is 70% in PWID and 77% in the spouses, which we are very happy about. We also started hepatitis C treatment, which Yasmin mentioned in detail. We are very grateful to Dr. Said for providing us free of cost advice on what medicine would best suit our clients. And we hope that we can further expand this treatment because I think more than 90% of our clients do test positive on the RDTs. So we really hope that we can provide more clients and spouses with treatment for hepatitis C. Then we are very grateful to the CDC for allowing us to provide differentiated ART services in Sindh. So far we have medically supervised 1,894 ARV refills among 754 PWID and 34 spouses. So the recommendations are a large-scale and low-threshold OMT rollout for PWID as soon as possible. We have been waiting for this for years, and the way it is coming in right now, it is unlikely to help our key population because it's limited to the government hospitals. We hope that this will soon roll out in the communities. Then differentiated ART services at the doors, steps to improve ART adherence and treatment. This is a massive issue in Punjab, as Salman Saab had mentioned before. There are thousands of people who could be retained on treatment, which we are unable to do because they do not want to travel to the ART centers. One thing that we really need for our clients is long-acting injectable ARVs. This would be a dream, and we hope we can find some way to get this for our clients soon. Scale up of treatment for hepatitis C, and laws and legislation to protect the constitutional right to life for PWID and their partners. This is most essential because currently in Punjab, the requirement for having a national identity card to be registered for life-saving medicine is a human rights violation. And we hope that other stakeholders and partners will also take notice of this and support us in supporting our clients to get life-saving medicine. Thank you.